Welcome. Our subject today is breast density and early detection. Today I have Dr. John West, who's going to give us a little history about himself as well as his specialty in breast density. Welcome.
Welcome, thank you. It's great to be here, and it's a fascinating subject, and it's so important. Right. This is maybe one of the most important interviews you'll do, because women are dying needlessly because of delayed cancer diagnosis, and it's easily fixed. It's not complicated, but the women don't know about it. We're going to tell them.
Okay,
they can read my book and a whole chapter on it, but this is so important. I can't overemphasize the importance as a breast surgeon to get the word out on breast density.
All right, well, let's talk a little bit about your history real quick and just kind of give us an overview of what you've done.
Okay, well, I've been in Orange County since 1973. Believe it or not, that's 45 years, hard to believe. I started out in interest in vascular surgery and trauma. And the last thing I wanted to do was breast surgery, because then we were doing radical mastectomies, and it was mutilating. I hated it. It was disfiguring. But after about 10 years in practice, we started coming up with mammography that was readily available. We came up with good, effective chemotherapy. We didn't have that before. We came up with reconstructive. My son's a plastic surgeon. We work together as a team, so I take it off, he puts it back on. But many of our women after breast cancer surgery say, well, I haven't looked this good in years, because they become youthful contour, and we take good care of them.
Right, good. Okay, excellent. And then, so now let's talk a little bit about the difference between breast densities. So I know we talked a little bit beforehand. How do we know the difference, and what are they?
That's a great question, because 99% of my patients come in and say, I have dense breasts. Well, you examine your breasts and it feels all lumpy, which breasts do. That's a normal sign of, that's just a normal breast to be lumpy. You can only tell on the mammogram. So forget trying to guess. If your mammogram report now by law either says you're primarily fatty or you're dense. If you have a more fatty breast, you don't have to worry. There's no extra imaging. And about half the women have a fatty breast, and half the women have a dense breast. At the younger age, it's a little more women are dense, but some women over time will convert from dense to fatty if they're lucky. Not every woman does that. But if your mammogram, you need to know what your mammogram says. It's not enough to say negative. Negative is not negative if you have dense breasts. So now, even though this has not been emphasized, women must be educated to learn that if their breasts are dense, they need more imaging, or they may miss a cancer and suffer the consequences.
Right. And so how does a patient know whether they should ask the doctor, or how do they know? Well,
here's how it works, and it's a little discoordinated. There's a law now saying that the doctor that orders the mammogram will get a report, and it's his duty that if it's dense, to tell a patient the mammogram doesn't work as well, and you either need an ultrasound or an MRI. Those are the two basic options. But the doctors are so busy now, they get the report back saying negative, and so they tell a patient it's negative. That's not enough. And the patients have to take control of this, or the women have to take control. The doctors, it's less than 1% of the doctors inform the patient. This is tragic. But the women need to know to ask. Just because it's negative, was I dense or not dense? It'll be written in every mammogram. So there's 4 categories: fatty, predominantly fatty, that's the half that are non-dense, and then there's dense and extremely dense. So if you're extremely dense, you really need the MRI, and you're higher risk for breast cancer. It's an independent risk factor.
And tell me why it is important for a woman to know whether or not she has dense breasts. I know we talked about it earlier. What is the extreme importance?
Well, this is a whole theme in my book, that if you want to get ideal breast care, you've got to take control. You've got to learn to do mammograms. You've got to know to get the right imaging. You know how to put this whole thing together: eat right, exercise, etc. And we just need to motivate women to take control of their health. So if they're going to get a mammogram and it says negative, they have to, which category am I in? And if the doctor doesn't want to explain it, they can read the report. The report says that you're in this category, you need extra imaging. Call up the imaging place, or call us, whatever. Call your doctor and say, hey, I want more information. If the doctor doesn't really provide you good information, and many of them won't, then you go to one of the breast centers like Breastlink, and you can get an answer. You can just phone in. You don't have to go pay the money or whatever. You call us, and we just feel that empowered about that. It's just so critical that they have that information.
Right, and other things that we can do to help prevent breast cancer. What are some other things?
Well, there's two ways of looking at breast cancer. One is catching it early, which really mostly our strategy, but the other is preventing it. So one example, let's take a woman who has the gene positive, very strong family history. She goes in for genetic testing. She tests positive for the BRCA gene. She looks at all her options. She says, well, I want bilateral mastectomy with reconstruction. You're going to prevent a cancer in that case, but that's pretty rare. And so prevention is really difficult. We know there's a drug, tamoxifen, that lowers your risk of getting breast cancer, but we really only use that for women who've had estrogen-positive breast cancer, estrogen-positive breast cancer. The general public generally doesn't want it because too many side effects.
Right.
So prevention is, you can exercise, you can eat right, limit the sugars and the carbs in your diet, keep your weight under control. Those are the three big things. Smoking seems to be correlated. So there are things you can do, but the big thing that women need to know now is early detection through imaging. The mammogram is wonderful, but it had one major problem up to a few years ago. We were missing small cancers, and they would come to us with a normal mammogram 2 or 3 years in a row and then present with a large cancer. I said, well, how could that happen? I just had my mammogram 3 or 4 months ago. Well, that cancer was there 3 years ago. They would have picked it up on ultrasound in all probability, not 100%, in all probability, and they could have saved their life.
Okay. So now ultrasound, is it done in the same location as the mammographies?
Well, different places. Most imaging centers can do the screening.
Okay.
It's very time consuming, and they don't push it very hard because it's not very profitable. Sure. And that's why it was hard for us to really get a robust program going. But after a while, they saw the advantage of it. Right. So at Breastlink, you can call a Breastlink facility and have no problem. But Hoag Hospital, St. Joe's Hospital, all these major hospitals have imaging centers. So if you're affiliated with Mission Community Hospital, you call them, they'll help you out. Okay,
great. Is there an age at what time that we're supposed to be educating young women about, how to do the self-exams and what to look out for?
Well, I wrote a whole chapter on this, but self-exam is underutilized. It's been poo-pooed by a lot of experts, but you can find a small cancer if you know your breast and you do it regularly and you follow my recommendations. They're different from the recommendations from the Cancer Society, because I've learned how to teach women to do breast self-exam with confidence and what to do if they find a subtle change. And we've saved lives because of that. So when do you start? That's a great question, and there's no crystal clear answer. Some young women, teenage girls, are interested in saying, well, what should I be doing? And so they should be told, don't do it before your period, do it 5 to 10 days after your period. Go to a doctor or a nurse, have an exam, make sure everything's normal, and then check it when it's normal. Don't go looking for lumps, just learn the pattern of the normal, do it once a month, and if something grows in there, you'll go, ooh, that feels different. Then you go in to see the doctor. And most of the time it won't be cancer, but if it is a cancer, you're going to save a life. Okay, all right. And then as we age, is it harder to find a lump or easier? Well, women as they age are more likely to have fatty breasts, so they tend to be a little easier to examine, but there's a lot of overlap on that. So younger women tend to have the dense breasts, and so we tend to miss more if we're not doing the ultrasound. But if you add the ultrasound into the equation, it's pretty much equal. But the reason it's harder in the younger women is they have more likely to have dense breasts, and most of them are not getting appropriate imaging with the ultrasound or MRI. And going back to some of the treatments, I know there's a lot of different treatments now that are being offered, and it's kind of specific to the type of cancer that someone has. In your opinion, what would you say has been some of the best advancements that we've seen in technology? Well, I've basically been lucky enough to see all of them. I actually started up in trauma care, and I was the first to develop Orange County into a regional trauma system, and then that was the first one in the nation, and I was really proud of it. And the basics of the trauma center is you have the surgeon and the neurosurgeon, the orthopedist, all the specialists, the anesthesia in the hospital all the time. And when when I started wearing out, because that's really tough to do, they call you in the middle of the night, and was getting a little older, things were changing in breast care. So chemotherapy, they didn't have chemotherapy when I started. The imaging was primitive, I mean really primitive. And they didn't have, reconstruction was almost unheard of. There were maybe Mayo Clinic or someplace you could get it, but it wasn't. But all of a sudden it changed, it just changed almost overnight. The imaging got extremely good. It took a couple of years, but it got extremely good. The plastic surgeons became fascinated with it. The oncologists, really had an important role in it. And finally I said, just like a trauma center, you need a team approach to breast care. So you need to have mammographic screening, dense breast, get the ultrasound. If they have a problem or a symptom or have a question, come in and see us. We'll do a simple exam. We'll give them the advice. They can either follow with us once a year, or they can just go out on their own and see us if there's a problem. If they do have a cancer, we're going to likely catch it really early.
Right.
The treatment then is almost always a lumpectomy. One of our big goals is to get around the cancer and clear the margins on the first operation.
Right.
So if you have a D or double D breast and you have a average size, quarter size cancer in the breast, you can take out that cancer with a very wide margin. Then I let the plastic surgeon bring everything up, kind of youthful contour. The nipples are pointing, straight ahead rather than down. And you match the other side, and these women can't keep their tops on. I say, look, will you wait until we get you into an exam room? I know you're pleased. I know you like what you got, but, hold on. It is great to have patients say, you look at them, you go, I can't believe how good you look. She said, I can't either.
Right.
I went through cancer and this is how I look. This is fantastic. Right. Even with mastectomies now, we're doing a lot of nipple-sparing mastectomy. Some of those women, again, we change the shape and we get an actual better shape. And the nipples look pretty much normal in most cases. They can lose sensation, that's the downside of it, but it's really, from a cosmetic point of view, it's step forward. Not every woman can we save the breast, and so sometimes, but the reconstructed nipples are really good. So we really want every woman who goes through breast cancer to get through it and say, I look as good as or better than I did before. And we hit that mark 90% of the time.
So tell me about your book a little bit. I know you have the title here.
Yes, that is Prevent, Survive, Thrive, Every Woman's Guide to Optimal Breast Care. And this covers it from A to Z. There's a lot more information on breast density. We just don't have time. The same with breast self-exam, the same with early detection, the diet and exercise, and all the things you can do. And then if you are diagnosed with breast cancer, there's a whole chapter on what you can do to make sure you understand what the doctor's saying and what kind of questions you should ask. So I think it's very valuable. Many of my patients have been very pleased with it.
Okay, kind of a guide to know it all, right?
It's exactly right. All your questions are answered.
All right, perfect. Well, thank you so much. It was very nice to meet you. Thanks for joining us.
My pleasure. Thank you.
And thank you for being with us.